think it's Mickey's PPT, which is being shared there.
Yeah. So I think we'll start in a minute or two. Will it be okay?
Yeah, sure.
Yeah. So, good afternoon, everyone. Namaste. Hi, I am Dr. Gunadhar Padi, Consultant Critical Care Medicine, Apollo Hospital, Navi Mumbai. And on behalf of Apollo family, I welcome all of you to this academic Apollo Knowledge Network of discussion. Today's discussion is diabetic ketoacidosis. As you know, this is one of the burning topic in most of the ICUs across the India, because the burden of the problem is more compared to what exactly we anticipate. So that is the reason this is the need of the discussion of the hour. So we have with us two speakers. One is Dr. Swarna Deepak. He is Consultant Critical Care Medicine from Apollo Health City, Hyderabad. And he is going to speak on the critical aspect of diabetic ketoacidosis management from the intensivist perspective. And Dr. Miki Patel, she is our staff nurse, who is going to basically speak on the nursing aspect of the management of the diabetic ketoacidosis. As you know, both the topics will be very interesting, I suppose, because these topics are complementary to each other. Because the role of intensivist and as well as the treating staff is very, very important in managing a patient, because every hour is vital, every minute is crucial, and every decision is very, very important in such kind of scenarios. That is the reason when the patient comes to the ICU in a critical state, the right decisions at the right time by the right person is very, very important. That is the whole aim of this webinar. So without taking much time, I think we'll start with the webinar. I first invite Dr. Deepak to just highlight us with the critical aspect of the diabetic ketoacidosis and its management. So over to you, Dr. Deepak.
Thank you, Gunadhar sir. At the outset, let me thank Apollo Clinical Excellence Group, Knowledge Group, and Apollo Hospitals as a whole for giving me this opportunity. Thank you all the audience for attending to this webinar. I hope at the end of this webinar will be much better than in our knowledge. And feel free to ask me at any point of time. Raise your hand, leave a question in the chat box. It's actually, I'll be learning more than you. And even at the end, it's fair enough to ask some questions. Just checking, yeah, my slides are visible, sir?
I think you have not uploaded your slides.
1 second.
Okay, so by the time you upload your slides, I just make one point of discussion that make this webinar a very interactive and interesting one, because we believe in knowledge sharing and also we believe in the distribution of the knowledge. So, whenever somebody faces any difficulty, we'll be taking the questions at the end of the discussion. And over to Dr. Deepak.
Yeah, is it visible now, sir?
Yes.
Okay, so thank you everyone. I will be jumping into the topic now. Before as any important topic, always it will be nice to start with a story. I usually start with a story. So here the story is about a patient, 18-year-old female, who presents to your ER with high-grade fever, a bit breathless. She is in altered mentation. She had been having diarrhea for 3 days, watery diarrhea, large volume diarrhea. That's how this patient presents to you. And on examination, she was found to be febrile, 101 temperature. She's tachycardic, hypotensive. Her BP is 90 or 70. And her GCS is depressed at a score of 9. When incidentally their GRBS was checked, it was showing as 480 milligrams per deciliter. She's not a known diabetic in the past. So remember this scenario. This patient at frequent junctures in the presentation, next 30 minutes or so, we'll be seeing how this patient travels through the treatment part, ultimately how the patient improves and what is the evidence for at each step. So just remember this female who presents to the ER with fever, high sugars, altered mentation, tachycardic, tachypneic, and hypotensive. Okay, so remember this patient. So before the brief background of diabetic ketoacidosis, you can see the picture on the extreme left upper corner. You can see the ward there. These are the wards who are filled with type 1 diabetic patients, young patients. Before 1920s, when the insulin was not actually invented or discovered, at that time it used to be having a almost huge mortality. Almost every patient in a type 1 diabetic, they never used to survive through the adolescence, and there used to be a lot of morbidity and mortality. And thanks to these two gentlemen, whom you can see, I think everyone recognize it, Banting and the Best. There, it was a miracle. Actually, they discovered the insulin in the pancreatic cells of dog, and they were further with the help of MacLeod, Collip, and other colleagues, they were able to isolate it in a pure form. And because of this, I think there was a huge change in the way the medicine was evolved. Yeah, as you can just, I'm like picture say more than any 1,000 words. As you can see the extreme right corner, you can see the baby, and when the mother is holding the baby, how emaciated it is, how bad the baby looks. And after the insulin, this is a difference between December and February. Once the insulin was given to the patient, the baby looks so healthy. And this happened to a lot of people over a period of time. So 1920s, that's the reason both of them were awarded Nobel Prize in medicine. So thanks to this gentleman, we'll just pay our gratitude to them and go into the topic. So right into the subject proper in the presentation, these are the headings which I'll be touching. So we'll be discussing the brief definitions, how the diabetic ketoacidosis is defined, what are the clinical features of the diabetic ketoacidosis patient, what is the basic pathophysiology behind it, what are the various diagnostic strategies, how do you manage a patient, and once you know that the patient is better, when do you transfer a patient from ICU to the ward, and what is the transition point. These are the small headings under which we'll be discussing the topic. So why is it important, diabetic ketoacidosis? It was first described in 1886, but as I told you very clearly, showing the picture, till 1920s, it is almost universally fatal. And believe me, it was a miracle at those point of time. And even now, maybe in a developed nation, the mortality may be less, but in developing nations, because of various factors, you can call it resource poorness or maybe unawareness, whatever it may be, there's still a significant mortality. And in some series, it was documented up to 40%, which is huge, especially considering that this disease can be solved easily and treatable. And it carries a huge economic burden in millions and millions of dollars on the nation. And what happens, even if the patient is partially treated and incomplete treated, even though the patient may survive this episode, but in the future, there will be a kind of stunted growth, the milestones will be delayed, long-standing sequelae will be there. So there's a huge morbidity. And in the mortality, specifically in the younger group and the adolescent groups are at higher risk of cerebral edema, which is the most common cause of mortality. Whereas in the adult population, it actually, the electrolyte abnormalities are the one which, and associated conditions, which I'll be going through in an interesting scenarios in the next slides. So they are the cause of death. What causes the diabetic ketoacidosis? Just imagine you, you're traveling in a ship and suddenly it submerges in the middle of the sea. You're surrounded by a huge water body of sea water, but you cannot drink even a drop of water because it's a salty water. So that same analogy applies here in the diabetic ketoacidosis as well. Even though your sugars are on the upper side in the blood circulating at the plasma level, but still the tissues are unable to use it because of absolute or relative insulin deficiency. And there's a compensatory mechanisms which are acting up and increasing the counter-regulatory hormones like glucagon, catecholamines. What do they cause? They cause increased hepatic gluconeogenesis and glycogenolysis. So it creates a kind of spiral circle where the sugars are high in the blood, but the tissues are unable to use. What does the tissues have a backup plan? Here, the lipid comes into the picture where there will be an enhanced lipolysis, which in turn will be converted into the ketone bodies. They convert as an alternative source of energy. But are they foolproof? No, they're definitely not equivalent to the natural mechanism. And at the same time, they have a side effects like it causes a huge acidosis as well. What does this other side effects of these conditions? There's these high sugar values and these things called a kind of osmotic diuresis causing like fluid depletion. That's the reason most of these patients are volume depleted at large volumes. And associated conditions, for example, this may be discovered by an associated myocardial infarction or a pancreatitis. So the associated conditions, especially when they landed into a DKA, they can in turn can have an increased mortality or morbidity without DKA. So all these things combined cause a sequel effect or kind of butterfly effect at the end of the this pathophysiology. What are the various risks and precipitating factors? First and foremost, you need to understand what is the type of patient which comes to you. If it's a type 1 diabetic, it can be an initial presentation. The patient may present to you like a diabetic ketoacidosis, or it may not be like that. Sometimes the patients with type 2 diabetic as well may present to you when especially they are non-compliant with the medications or even and then stop taking insulin, or when they don't understand the sick days. So sick days is a concept where during the sick days, for example, a patient has a fever, patient has some kind of stress on the body like a trauma or something, the stress on the body increases and the sugars actually shoots up. But a naive patient, maybe an illiterate patient may not know that, and they subconsciously what they'll do, unknowingly they'll decrease the dose of insulin, they decrease the dose of anti-hyperglycemics, and it in turn causes a high glycemic state and which pushes the patient into a diabetic ketoacidosis. Associated other conditions like myocardial infarction, CVA, we've seen patients, I think most of us who regularly work in the ICUs, they must have seen a patients who actually presents with a myocardial infarction. When you see the patient, the sugars are high and the anion gap is not explained by the primary condition. And when you go in search of it, then you'll understand that the patient has an associated DKA as well. This applies to the other settings like a surgical setting like appendicitis, pregnancy, and sometimes that may not be very clear to you. The pictures, the patient may be taking a sympathomimetics. They may be recently started on a corticosteroids, especially this is recently we have been seeing after the especially during the COVID state, where the patients were taking steroids at the home and they land up into the DKA. So these are the various precipitating factors which can push the patient into a diabetic ketoacidosis. Once you understand that there is a risk of DKA of this patient, it is basically a few of the hyperglycemic emergencies. How do you diagnose it? So the name explains, it is a self-explanatory name. DKA, that is D is diabetic state where the sugars are high. It is more than 198 or approximately 200, and or the patient may be known to have a diabetes mellitus or may not known to have a diabetes mellitus. This is an exception in another setting where euglycemic ketoacidosis, which we'll be discussing in the last slides. Second must scenario is ketones, presence of ketone bodies. Rather than a presence of urinary ketone bodies, presence of ketone bodies in the plasma or blood is the cyanoconon or quintessential criteria. So it should be more than 3 millimoles per liter. And third criteria, which is definitively required, is acidosis, defined by either a pH of less than 7.3 or concentration of bicarbonate less than 15 millimoles per liter. So once you know that three of these criteria are satisfied, you know that this patient has a condition called DKA. And this is a new criteria which was given by the British criteria, and some various criteria like ADA, they slightly difference will be there, but the concept remains the same. So again, going back to our initial friend who presents to the ER, what do you want to do? So the first step which you need to do, either in you're handling in an emergency, either in a peripheral setup or in an ICU, you need to resuscitate the patient. So the resuscitation, evaluation of the patient, go and management of the patient, all of them goes hand in hand, especially in this scenario. So we need to first secure a wide bore peripheral catheters and start volume resuscitation. Always remember, fluid management and electrolyte management always comes before insulin therapy in a diabetic ketoacidosis patient. So this is very important and very commonly done mistake at the grassroots level, which you need to never should be repeated at our level. Central line, it is essential or not, you need not always keep a central line. The indications for central line is basically when the patient has other organ dysfunction, significant acidosis, severe hemodynamic compromise, or when the patient has an associated condition which requires multiple infusions. These are the conditions where you require a central canal, but you can always start with the peripheral lines and always start with the resuscitation with crystalloid. There's no role of colloid. Normal saline is the well accepted and well researched crystalloid in the various fluids. And make sure, as I told you, before you give any kind of insulin, make sure that the potassium values are checked, and it should always be more than 3 or 3.5. So our friend, the step 1, the resuscitation was started. What do we do in the second step once you start the resuscitation? As I told you, empty mind may not do too many miracles. So you need to understand where you're going. You need to chart your territory. So you need to go and take the history of the patient, examine the patient. In a focused examination and history taking, you need to ask if there's a drug non-compliance, especially the anti-hyperglycemics, or search for the leading history which could have precipitated the diabetic ketoacidosis. As I told you, maybe a vascular accident, maybe an infection, whatever it may be. Or sometimes it may be a first presentation without any other incident factors. And in the physical examination, go and look for clearly the infective foci, maybe a pneumonia, maybe an appendicitis, various kind of things you can always trigger. And in the drug history, always look for history of SGLT2 inhibitors, which are, I think, being increasingly used in the nowadays with their good cardiorenal benefits. We'll be discussing at the last, but make sure that you ask the history of this drug, because remember, the sugars may be normal with this drug, but still the patient can go into a diabetic ketoacidosis. So again, we go back to our patient. Can you have any other differential diagnosis? So this patient has a gastroenteritis, diarrhea. It could have a gram-negative septic shock, or it can be a severe fluid loss, which can go into a metabolic acidosis. Can it be a honk or hyperglycemic state? We'll come to it. Can it be a pancreatitis? Unlikely. When you other common differential diagnosis for this DKA is high anionic gap metabolic acidosis. You can have a combination of alcoholic ketoacidosis, combination of starvation ketoacidosis, psychiatric patients taking a salicylates or other kind of antipsychotics. And the last entity is the renal patients, especially diabetic patients with long-standing diabetic nephropathy. They may have an associated end-stage renal disease as well. Here it will be a huge confusion, which is the acidosis which is dominating. Is it a DKA component or is it a renal acidosis component? So we'll be discussing in detail. The reason for this slide is you need to understand there is a lot of differential diagnosis as well. So is it a hyperglycemic hyperosmolar state or DKA? Usually DKA presents with a significant ketoacidosis where the ketone acidosis is minimal in a honk or HHS. Sugars are much higher in HHS because the insulin levels are always in a usually normal state, whereas almost minimal state in DKA patients. The osmolarity will be very high in a HHS. Usually HHS presents in an elderly group where DKA presents in an younger group. The onset will be much more acute in a DKA where it is a chronic condition where the patients are usually elderly. It develops over a period of time and has a very poor prognosis in HHS. And they may present with seizures, and coma and neurological symptoms are pretty common in HHS. And dehydration, it is there in both of them, but the amount of fluid you need to give in HHS is much higher when you compare with the DKA. This patient, we all know that this patient has a DKA. At this point of time, you need to classify whether it's a mild DKA, moderate DKA, or severe DKA. How do you understand? One thing to understand is any patient who has a hemodynamic compromise, who has an organ dysfunction, extremes of age group, like very elderly group, very younger age group, or special groups like pregnant ladies, renal dysfunction patients. These patients, you need to have a very lower threshold to admit them into an intensive care unit. Purely talking on the numbers, mild, moderate, severe decay, you can classify based on the pH. Severe decay is when your pH is less than 7 and bicarbonate is less than 10 in severe decay. And don't go looking for the number of plus in urine ketones. It may not actually reflect the severity of the decay. Anion gap is one thing which can actually give you an idea of severity of the acidosis in the body. The more severe it is. Mental state, definitely the more severe the DKA or HHS, the more stuporous or comatose the patient will be. So if we are clear till now, you can will be proceeding to step 3. We resuscitated this patient. We have basically took the history and done the physical examination of the patient. Decided whether to admit this patient into an ITU or ICU or into the ward. What are the investigations you need to send? To send any investigations in any type of patient, not only DKA, you need to understand the disease pathophysiology and evaluation of the disease. So here we know that this patient has a high sugars, which already we know it. So you need to repeat at serial levels. And obviously we know that there's a lot of electrolyte disturbances. You need to send a basic metabolic panel, which includes a magnesium and phosphate. The reason I kept magnesium phosphate is usually we'll tend to do the potassium and forget to do magnesium and phosphate. And creatinine and blood urine nitrogen, you can do it, but may not repeat it very hourly frequently. You need not every time do an ABG, you can do a VBG as well. Complete platelet count may give you an idea about the neutrophil count, amount of infections. Between the serum ketones and the urine ketones, always the serum ketones are the one which is more useful for you. ECG, chest X-ray, try to always do it, because as I told you, many of the times cardiac coronary artery disease, pneumonias, these are missed, and will be going and treating the DKA, but forget to treat the precipitating factor. And always better to send a cultures to see if there's an occult infection. So as I told you, these are the numbers. How do you decide the assessment of severity? This slide is self-explanatory. Any patient who has a severe acidosis with bicarbonate less than 5, these are basically very severe acidosis. This patient inherently will be getting admitted into the ICU. So our patient, we send the labs, we done the initial resuscitation in the emergency. We evaluated briefly. And now our management will be starting. We will be going into the initial management and we'll be discussing in the evidence part. So the management has 4 prongs. The 4 prongs are fluid resuscitation along with electrolyte abnormality correction. Second thing is IV insulin therapy. These are the basic 2 steps. Along with it, you need to watch for the complications of decay, complications of the decay, complications of the treatment which you're giving, like insulin may cause a hypoglycemia, may cause a hypokalemia. The complications of the fluid you are giving may cause a fluid overload, pulmonary edema. So these are the complications you need to watch for. At the same time, 4th thing is you should never forget to identify the precipitating cause and treat the precipitating cause, without which every time the decay again will not be reversed. So this is the basic thing you need to give. A to D. Airway, breathing, circulation, we all know. Always try to involve a senior diabetologist team, endocrinology or critical care team or physician team. E is electrolytes, fluid replacement. This is basically a mnemonic which you may remember. So coming to the fluid therapy, we all know that these patients are extremely fluid depleted because of the osmotic diuresis, because of the decreased intake, maybe because of vomitings, pain abdomen, whatever it may be. How does the fluid which you give help the patient? It basically restores the circulatory volume. It will improve the turgidity of the vessels. It clears the ketones into the urine, and it again corrects the electrolyte disturbances when you are replacing with the potassium in the normal saline. And always remember, you can have two conditions where the patient may be hypotensive, where the systolic BP may be less than 90 millimeters of mercury, or the patient may be normotensive. So your approach is, when your patient is a hypotensive patient, your approach remains the resuscitation of the patient, like your any other septic shock patient or any other shock patients we'll be discussing there. Where if your BP is more than 90 millimeters of mercury, you'll be going to replace the fluid at a fixed intervals. At the same time, trying to watch to avoid over resuscitation. So these are the common deficits in the diabetic ketoacidosis or HHS. Almost 6 liters of fluid is deficit in an DKA, whereas it is 9 liters in HHS. Sodium, chloride, potassium, phosphate, all these ions are grossly depleted in both these conditions, where it is much more profound in HHS. So in this patient, what have we done? We initially gave the fluid, as we know. We resuscitated the patient because you remember the patient, as I told you to remember this patient, she was hypotensive. So we resuscitated with a 15 to 20 milliliters of kg, normal saline first couple of hours. Then the patient's blood pressure started picking up. After the initial bolus, always you can cut down the fluid. You can go to the baseline fluid. I will be discussing the nomogram in the next few slides. But the point you need to understand is, once your initial resuscitation is done, then try to not over resuscitate the patient, because there are some problems like cerebral edema, hypernatremia. These kind of complications may occur. So that's the reason, especially you need to keep a watch on the sugar level as well. Especially once your sugar comes to the GRBs comes to around 250 or something like that, you need to switch over to the fluids which contain dextrose as well. Another thing is, half normal saline also may help you, especially when there's a hypernatremia. When you're replacing a potassium chloride also contains a chloride. Basically, it is diluted in a normal saline containing fluid, where it increases the tonicity of the fluid. So you need to switch out to the half normal saline. When you're resuscitating this patient, one thing you need to remember, large volumes of normal saline, as we all know, it creates a kind of hyperchloremic acidosis or non-NGAP acidosis, where you'll be confused whether DKA is again coming back or is it a new kind of acidosis. Your delta gap or gap ratios will help you here. So these are the groups of the patients which you need to admit into the intensive care unit, and central line may be required, and where you need to be very, very careful when you're shifting these patients back to the wards. Remember, any patient who has these kind of pictures, when you're shifting back to the room, it's a pretty dangerous thing. So you need to be very careful. As I told you, the setting where younger group, elderly group, pregnant ladies, heart and kidney failure, or when you have an organ dysfunction. So just a brief review. Your management is on these three lines: diagnosis, where you know that the sugars are high, your ketone bodies are high, and there's an acidosis. And your immediate management can be divided into three parts. One is from the zero hour, or from the point you diagnose the DKA, that is 0 minute to 60 minutes, that is in the first hour. In the first hour, your whole goal remains to replace the fluids, preferably a normal saline, evaluate the patient, send a basic panel, try to get the serum electrolytes, especially the potassium bicarbonate and phosphate, and try to correct them to the normal range before you start a insulin therapy. This is in the first part. So this was the part which you're discussing. When you're replacing a fluid, keep a watch on the systolic blood pressure. If it is less than 90, your standard fluid resuscitation goals, like any other fluid resuscitation you do, which applies. And what do you do when the potassium is on the lower side? Try to avoid the insulin at all cost if it is less than 3.5, and to try to take a senior's input, senior physician's input. And it is between 3.5 to 5.5, you need to replace around 50 millimoles. It depends on your ICU protocol, the patient, is it a renal patient or cardiac patient. Whereas if it is more than 5.5, you need to repeat again after hour or 2 hours, and then need to reassess. So we'll just take a hold. Any questions you can again keep in the chat box. So moving forward to the second part, that is after 1 hour to the 6 hours. Here you've done a good job in resuscitating the patient in the first hour. Your aim is to avoid the complications rising from your treatment. Start a proper insulin therapy, cut down the sugars at an expected level. Expected level of decrease in the glucose is between 50 to 75 milligrams per deciliter. And your ketone body should fall at least 0.5 millimoles per liter per hour. If you cannot check if serum ketones at your lab, you can always check a bicarbonate. Bicarbonate should raise at least by 3 millimoles per liter per hour. Every hour you're doing your job in a proper way. If you're not doing that, again reassess the patient and see if something is going wrong. Either it's from the patient side or either it's from the treatment side. So this, I think we've discussed. The fluid, once you resuscitate the initial fluid, maybe you're given a 500 ml or 1 liter in the first hour, then you go and replace with the next 2 hours with the potassium chloride. Always in the next 2 hours, you need to replace with the potassium chloride in the normal saline. The same thing applies. So there, as you can see, 1 plus 1 plus 1 over 2 hours, 2 hours and 4 hours. And after this, once you identify that your sugars are falling less than 252 or 14 millimoles per liter, you need to add the 10% glucose or 5% glucose to see that what are we trying to see? To avoid hypoglycemia, because there is something called as rebound hypoglycemia in this patient, which may has a propensity to kill the patient. So here your goal is to balance the osmolality, avoid the cerebral edema, and avoid the hypoglycemia. And you can always cut down the insulin infusion to half. That is, once usually will be starting at 0.1 units per kg per hour, you can cut down to 0.05 units. We'll be discussing the insulin. So what do you do in our patient? We started the fluids, we seen the potassium, we started the insulin. As I told you, if things are going in a proper way, that means you're doing your good job. That means your bicarbonates are increasing, your acidosis is improving, your ketones are coming down, your sugars are coming down. But if it is not happening, what do you want to do? You just go back to a step, reassess the patient. Usually our approach at our unit has been man, machine, and the circuit. That is something going wrong with the man or woman for that sake? That is the disease flaring up? Is there a sepsis which is worsening, which is causing much more and more decay? Or is the drug being delivered properly? For example, insulin may not be loaded in a proper way. It may be not stored in a proper way before, or maybe a wrong insulin is being given. That may be a cause. And lastly, connections. Always check the connections. Many of the times we find the circuit may be not properly connected, or you may connect to a cannula where it is actually not, there's no proper flow in the IV cannula, and the most of the medicine is going out. So just check it, go back and check it again if your things are not working. And rest of them, I think most of us will be knowing the routine ICU care you will be doing, like thromboprophylaxis, kind of ECG monitoring, all these things. I don't think you're knowledgeable enough to know it. So once you know that, after 6 hours, what you want to do, there are 2 stages, that is 6 to 12 hours and 12 to 24 hours. So in the 6 to 12 hours, obviously you'll be monitoring the biochemical parameters again. You'll be continuing the IV fluids. Just reassess if you need to give too much of fluid, or you can cut down the fluid. And definitely you need to understand this is a stage where actually the hypokalemia, hypomagnesemia, hypophosphatemia, all these things can occur, especially when the patient is very frail person. So keep a watch on those things in this stage. 12 to 24 hours is the stage where actually most of the settings patient should have been improved by now. By 24 hours, if your patient is still having acidosis, still having ketonemia, definitely something is going pretty badly wrong, and you need to understand what is going on and call a good senior, talk to them, reassess the patient again. And obviously between this stage, you should not have a DKA. So this is a summary slide where I'll be touching in the last. Don't worry too much here. There's a diagnosis, decision about where to keep the patient, fluid therapy, insulin. You'll be continuing the fluid, you'll be cutting down the fluid and monitoring for the complications of the treatment. How frequently do you need to check it? Hourly glucose should be done. Bicarbonate and potassium should be done at maybe an hour or 2 hours, depends on your feasibility. Once it comes down, the sugars are falling, you need to be watching for the hypoglycemia. So these are some controversial areas where I thought I'll just put a word here. I think someone is writing something on the screen. If they can avoid it, would be nice. Considering colloid versus crystalloid, always your choice is crystalloid. Never go for a colloid. Is it a normal saline or is it a kind of a balanced solute like a RL or plasmolite? There has been a lot of studies, lot of RCTs as well. But at this point of time, the consensus is still the normal saline is the first fluid of choice for the resuscitation. Well read, well studied fluid. So always go for a normal saline if it is if you are reasonable enough. And rate of fluid replacement we discussed. IV bicarbonate, it's a very controversial thing. So very common mistake which is committed at a very like basic level, naive level is given an IV bicarb. Never do that. It has a propensity to cause an intracellular acidosis. It can actually increase the sodium to a much higher level, go into a pulmonary edema, and the cerebral edema chances, all of them are pretty huge. So there is no indication of intravenous bicarbonate unless until it's in a dire circumstances where your pH is really low, 6.9 or something like that, where you don't know what to do. Apart from it, don't give it. Intravenous phosphate, then your phosphate is less than 1 milligrams. And the setting is starvation acidosis, when the patient is really malnourished. When you're giving a lot of insulin, the patient may be pushed into a refeeding syndrome. That is the scenario where you will be giving an IV phosphate. And rate of glucose lowering, as I told you, it should be 54 or 50 to 75 max. So most of our presentation has been like briefly completed. Now I'll just revise it in the last 5 or 6 slides. So what are your targets? Your targets are reduction in the blood ketone concentration, increase in these are the targets. You need to have a target before you start your battle. These are your targets. Correction of electrolytes we have been discussing. So one thing you need to remember is there is a correction factor of sodium. Especially there's something called as pseudo hyponatremia, when your sugars are high, you need to correct it. So don't keep on correcting it unless until you know the actual value. Rest of them, I think they're self-explanatory. This is a nomogram. I think we've seen in the how much potassium you need to replace. I think it's self-explanatory, where more than 5 or 5.5 you won't be treating it, whereas less than 3.5 you need to treat it with 20 to 40. Between it is depends on your clinical decision. I think we discussed 3 of them. So insulin therapy, 2 slides about the insulin therapy. There is something called as fixed rate insulin therapy, and there is something called as variable in the rate insulin infusion. Fixed rate insulin infusion is 0.1 units per kg per hour, where it is fixed for every patient, which is the standard of care for any ICU all over the world. So it is a brief table. You can always remember 40 to 49 kgs around 4 units, 5 units, 6 units. As you can go through the slide, no, you can understand it. Any patient who requires more than this, more than 0.1 units per kg, you need to again go back, sit with your senior and see why this patient is requiring so much of insulin. Okay. So the second part is the part where your sugar comes down less than 250. There you'll be cutting down to the half of it, where you're giving 4 units, you'll be going to the 2 units, and vice versa, like so on and so forth. Whereas variable rate insulin is where once the patient, you know that the patient is stable, you will be changing the insulin as the sugars change. So one common thing, and which may has a dreaded complication of death, is hypoglycemia. Always remember it. So insulin acts at 3 levels. It suppresses the ketogenesis, it reduces the blood glucose, at the same time it corrects the electrolyte disturbances. As I told you, the first slide, it's a life-saving therapy thanks to Banting and Best. I think these are most of them we discussed. One point I would like to highlight in the pediatric population is they are very high risk of cellular edema, especially the cerebral edema. So any pediatric patient or in a very younger to adolescent group, if the patient had a new onset seizure, a new onset altered mentation, when you are giving a treatment for DKA, suspect a cerebral edema and act quickly. 3% normal saline or mannitol or basically whatever is the routine anti-ICP measures you need to give. No, so you need to be aggressive in it because it again has a propensity to kill the patient's cerebral edema. So our patient, the patient who came in the first part, we treated them, we gave insulin, we given the fluid. How do you know that this patient has improved or not? So very common things, 4 indicators are: the patient feels better, they'll be taking oral food, usually at least 2 meals they'll be good to take, and the anion gap will be usually closed. As we seen in the initial set, the anion gap actually reflects the amount of decay. So the anion gap is closed and the bicarbonate will be more. So these are the basic indicators that the decay has resolved. And once the decay has resolved, one common mistake which can be committed is stop the IV infusion immediately, insulin infusion. And once we stop it, then switch on to the subcutaneous insulin. So which is a common mistake to do. Remember, it takes a bit of action. It's a time for subcutaneous insulin to act. So intravenous insulin infusion should not be stopped immediately. It should be stopped only after 30 minutes after your subcutaneous short-acting insulin has been given. Okay, this is a pretty good point to remember for you. And at the same time, if the patient was already on long-acting insulins, don't discontinue them. So we see in this patient, we treated them. Now that we know that this patient has improved, the decay has resolved. What are the complications which can occur? We all know hypokalemia and hyperkalemia are pretty known things to occur. So you need to make sure that they won't be there. And if they are there, you need to identify them in a right time and treat it. Hypoglycemia and cerebral edema we have discussed. Other less commonly recognized complications are venous thromboembolic diseases, especially when you keep a central veins. For example, you keep an IJV or femoral central line, the thrombosis may be there at this point because it's a hypercoagulable state, and transient AKA may there, but usually the fluid resolves it. If you are overzealous in your resuscitation, it may land up into pulmonary edema. Pancreatitis or raise in the pancreatic enzymes are pretty common, or on the other side, pancreatitis can also present a decay, precipitate into a decay. Cardiomyopathy can be there. They may go into rhabdomyolysis, and GI bleed is not pretty uncommon. So last 2 slides about the patients. This is a special group discussion where when the patient has a renal disease, what do you want to do? Why is it important to discuss separately? The insulin is cleared by the kidney. So obviously when your kidney is impaired, what will happen to the insulin? There will be a relative increase in the insulin levels in the plasma. That means the ketoacidosis part is actually less when you compare with the non-renal patients. That is, the insulin will be staying in the plasma much more. And another confusion which may occur, as I told in the first slide, is there may be a component of renal acidosis because of the chronic metabolic acidosis, which will be treated by the dialysis or which will be treated by the bicarbonate. Here you'll be confusing how to treat and what to treat. Another one relevant point is the beta hydroxybutyrate concentrations are actually less in the end-stage renal diseases, and you need to depend more on the anion gap and glucose levels, whereas other values are not done relevant. Fluid replacement in the renal patients, you need not be very aggressive, and you should not be very aggressive like when you're replacing in the patients of other non-renal patients. In fact, in some settings, you may not be needed to give the fluid as well. And one thing is there will be an inability to develop osmotic dialysis because of the kidney failure. So dialysis associated hyperglycemia and ketosis can occur without a presence of dehydration. So the insulin remains the standard of care there. Potassium, the hypokalemia is not that common, and in fact hyperkalemia may be more common in a renal patients. So don't go and aggressively in treating the potassium replacements like a non-renal replacement patient. Last 3 slides in the presentation about the special settings, like there is something called as ketosis prone type 2. You may not always have a type 1 diabetes mellitus presenting into a DKA. So it need not be our classical patients like your first patient, no, we seen, right? It may not be like that. Okay. It can be a type 2 patient who presents with a DKA as well. So this is called as flatbush diabetes or ketosis prone diabetes. It has a special pathophysiology. Remember, one thing you need to remember is this is a special setting where the treatment remains the same, insulin and fluid replacement. But after the specific treatment, after one setting or two settings after the insulin treatments, usually patients may go back to the oral hypoglycemic agents and they'll have a routine course as any type 2 diabetes mellitus. So coming to the end of our presentation, last story to tell you. So I'll be signing off with last story. So this is a woman in 40 years, type 2 diabetes mellitus, being treated with the metformin, pioglitazone, and empagliflozin. This is a SGLT inhibitor. So basically, she is admitted for moyamoya disease and some vascular procedure, extubated and transferred to the intensive care unit. Post-operatively, she developed a slurred speech, diagnosed to be having a cerebrovascular accident, resuscitated with fluids, standard of care. Next 24 hours, this patient continues to develop a progressive metabolic acidosis. The pH continues to be falling down. The pH is 7.01, whereas the anion gap continues to rise into the higher levels, that is approximately 27. You usually treat in a vascular patients, usually you'll be thinking about lactate acidosis, but here the problem in this patient was the lactate was normal. So as any other routine intensivist, we have started a bicarbonate for this patient, but still the patient continues to be deteriorating. So here, what do you do when you don't know, like you're doing something unknown and you're failing there? As I told you, always you step back and reevaluate. Here, the clinicians have done that. Presence of near normal blood glucose concentration in this patient. Initially, they thought the DKA was not possibility, but when you go back and saw the history, this patient took the empagliflozin 18 hours before the surgery, and sometimes it may act up to days, SGLT inhibitor. And the urine analysis revealed ketone bodies and the plasma ketones were also positive. So the diagnosis was euglycemic DKA. And the reason was SGLT2 inhibitor. And once the patient was known to be having a DKA, obviously the treatment remains the same and it was treated. So your point is never to miss this one, even it is rare. Basically, this drug creates a condition of insulinopenia. At the same time, it creates a glycosuria where they'll be dehydrated and causes a DKA. One common condition which you encourage, starvation ketoacidosis, where the patients are malnourished. They may be having an associated diabetes, but usually this patient will be chronically taking less because of various factors, and this starvation ketoacidosis may mimic a DKA. Here, one thing you need to do is the addition of exogenous insulin. If you do in this patient, if you are very aggressive in treating with this, thinking that it is a DKA, it may push the patient into hypoglycemia and refeeding syndrome. So the treatment remains treating with a carbohydrate like glucose supplements. Alcoholic ketoacidosis is the last differential diagnosis. The common differentiating factor is where usually the blood glucose is usually low or normal, whereas significantly high in DKA. Provided you know that SGLT2 inhibitors. So remember the special groups. And the take-home message for you is the treatment, the diagnosis. Diagnosis is based on the three factors, as I told you: elevated glucose levels, presence of ketones, low pH or bicarbonate. Decide whether the patient is fitting into the intensive care unit or into the ward. Be good in fluid replacement, follow the norms, and at the same time avoid the over resuscitation. Always collect the electrolytes, especially the potassium, before you start the insulins, and continue to replace the fluid. And once you know that the sugars are fallen to 250 around R, then start the dextrose containing solutions, and have a specific protocol for your intensive care unit, how to monitor the sugars at how frequent level, bicarbonate frequent level. And once you know that your decay is not resolving, go back and re-evaluate. And don't miss the conditions like euglycemic ketoacidosis, starvation ketoacidosis, and alcoholic ketoacidosis, where your clinical decision may save the patient. Thank you, everyone. Thank you for patient listening. I think I'll be free to take the questions after the next seminar. Thank you.
Yeah, thank you, Dr. Deepak. I think it is a wonderful presentation, very lucidly described, well understood. So the take-home message is very, very clear. I think whenever the patient comes to us for some kind of diabetic emergencies, so the first thing is to anticipate, and that should be a high index of suspicion, which is very, very important. Because all the decay may not present with high sugar. That is what you have also described in your lecture. And the second thing is to know how the burden of the problem is, how severe it is, depending on the anion gap in the acidosis. And third is to categorize into different categories, like whether it is a mild, moderate, severe kind of decay or hyperosmolar coma, and treat them accordingly. So the management is also very important, and simultaneously to know the complications like thrombotic states, like cerebral edema, and like different neurological presentations. So I can say diabetes is not only a single disease, diabetic ketoacidosis, but rather it is a multi-systemic involvement. It is a syndrome. So one has to look at every aspect of the patient, starting from the cardiac evaluation, starting from the nephrological point of view, because they may find sometimes the creatinine and BUN may be very high, and this is fallaciously high because of the presence of ketone bodies. There may be high counts, but there may not be any infection. And fever is sometimes very, very common. The decay can mimic like acute abdomen. It can mimic like acute pancreatitis. So all these things need to be ruled out. So it is a multi-systemic involvement. Very nicely described. I think we'll take the questions at the end of the session. And now I'll invite our next speaker, Miki Ben Patel, she is basically the ICU nurse at Apollo Hospital, Ahmedabad. And she is going to talk regarding the nursing care aspect of the diabetic ketoacidosis patient. So over to you, Miki. So Miki, are you there? So in the meantime, Dr. Deepak, by the time she is loading with her slides, there are a few questions in the chat box from the audience. So the one thing is regarding the electrolyte correction. So it is a very well-known fact that even if the serum potassium level is initially high because of the transcellular shift of the potassium because of the acidosis, but the overall potassium deficit is in the range of almost 300 to 600 milliequivalent. So whenever you treat a patient for this decay, so it is very important that you should correct the potassium initially, and you should also look for the thing that the patient should not go into arrhythmias. So how do you correct the potassium in such scenario? What is your protocol? So one question is if the serum potassium is less than 3 milliequivalent per liter in decay, so in when to start the insulin therapy for such patient?
Thank you for the question, sir. I think as we clearly discussed in our presentation, at least till the potassium is more than 3.5, or at least you know that the setting is safe enough that these low potassiums will not cause any arrhythmias or any antecedent complications, you should not start insulin. You should always try to correct the potassium first, get it at least above 3.5, and then only you should start the insulin.
Okay, so I think most of the electrolytes, they are deficient in a patient of diabetic ketoacidosis. If you see, they go into hyponatremia, severe hypokalemia, hypophosphatemia. There is a deficiency of magnesium. So there is a deficiency of calcium also. So I think that is one of the important aspects to correct the electrolytes simultaneously along while somebody is treating a DK patients or treating the sugar. The second question is, I think it's asked by one of the audience, how to address the pediatric decay. So if you can throw some light.
Pediatric decay, it was very clearly given in the international guidelines that any decay in the pediatric group should be managed under different guidelines and with a specific team rather than the adult team which is approaching. The most of the guidelines, you need to balance the fluids based on the kg body weight. And you should not apply the fluids and these things in the adult guidelines. Second most important thing is avoidance of the cerebral edema. Younger group are pretty vulnerable for the cerebral edema. That is one thing you need to be very careful about. And once you know that the patient has recovered, you need to maintain the optimum nutrition as well. The younger people, the nutrition is again something which is not in your control. So it may go back into the previous states. I'll be sharing the document of the pediatric guidelines, sir. I think the next presenter will be starting.
Okay, thank you, thank you. I think we'll start with the next presenter, Mickey, and then we'll take a few of the other questions. Yeah, Mickey, you are there. We are not able to see your slides.
Doctor, I think she just had some technical issues. She's just re-logging in again, doctor.
Okay.
Didn't get the slide. Namaste everyone. Mickey Patel from Apollo Hospital, Ahmedabad. Thank you, Apollo Center of Excellence in Critical Care, to avail this opportunity to me. Thank you, Dr. Gunadhar Padi and K.S. Deepak, to explain us in detail about DKA. Now, I'm begin with nursing perspectives regarding diabetic ketoacidosis. What we should monitor as a nurse when patient arrives with DKA. I justly go through about definition and then start with the nursing management. The first initial definition of DKA is a serious diabetes complication where the body produces excess blood acids, which known as the ketone. So it is a complication of diabetes in which there is excessive production of ketones in our body. So it is known as diabetic ketoacidosis. This condition occurs when there is enough insulin in the body of a patient. It can be triggered by infection or any other illnesses. As we know that if there is a lack of insulin in the body, so it happens that decay. The causes and the risk factors are the missed insulin dose. If patient is not taking proper insulin, or he or she miss the dose of insulin, they are taking 10 unit in morning, 10 evening, 10 night. And if any one dose or two dose they skip, then the chances of decay is more. There are sick or stressed components. They also cause the decay. The trauma in any organ of the body that leads to decay, maybe the liver injury, the kidney injury, they can cause the decay. These all are the traumas which can trigger the diabetes ketoacidosis. Some medications they can cause, and the risk factors for the DKA. The list of the medications are corticosteroids. Maybe the patient is taking corticosteroids for long time, and the diuretics, especially the thiazide diuretics and the sympathomimetics, if patient is taking, then the risk of diabetic ketoacidosis is more. The continue with the continue with the causes and the risk factors. Decay can happen to people. It is also happening in the type 2, but it's rare. If patient in diabetes, type 2 diabetes, especially when patients are older and more likely to have a condition such as hyperosmotic hyperglycemic non-ketotic syndrome, then it can lead to severe dehydration. So what nurses should monitor in that? So if the patient is thirst, we should identify the symptoms. Here is the list of the symptoms. Patient is thirsty, the heartbeats, then headache, less urination. If patient is having this kind of symptoms, the disease is showing the symptoms of hyperosmolar hyperglycemic non-ketotic syndrome. So nurses should monitor this kind of symptoms in the patient when the patient comes with type 2 diabetes. So we can easily identify the causes of decay and the risk of having decay. The risk continue with the stomach illnesses. If patient is having pancreatitis such as stomach illnesses, so there is a risk of having decay. The recent stroke patients, if patient is having any stroke recently, so they prone to get diabetic ketoacidosis. Then pulmonary embolism, patients who's presenting with a pulmonary embolism diagnosis, so maybe they have a risk to get diabetic ketoacidosis. The lady with pregnancy, it is also high risk category to get a decay. Surgery, the patient underwent from the patient we received after surgery or underwent recently in surgery, so they are prone to get DKA. The antipsychotic drugs, those are taking antipsychotic drugs, they are having chances to get decay. Then the another risk factor for decay, that is infection. In infection, we can take the pneumonia, also the urinary tract infection and the pancreatitis. These are the common infections we see in the ICU patients. So they are prone to get diabetic ketoacidosis if patients arrived with the pancreatitis or urinary tract infection, and some pictures of pneumonia or sinus symptoms of pneumonia we can identify. So we need to know about patients' risk about the decay. So these all are the risk factors. Those can get diabetic ketoacidosis. The test and the diagnosis, as sir explained about blood tests, including metabolic panel and electrolytes, potassium 4 to 6 hourly. We should send properly. The sample should be proper and adequate in amount. So we need to monitor as a nurse. We should have to take care about the sampling part. Urine analysis also we should send for decay patient. The EBG, it should be there once daily. Test for signs of infection. There are some culture tests like blood test, blood culture, urine culture, tracheal secretion cultures. If patient is on ventilator, then we should send the cultures of the patient. The chest X-ray should be available after the chest X-ray should be there to identify the decay. Electrocardiogram, the acetone level, the important test in the diabetic ketoacidosis is the acetone. As a nurse, we should monitor the acetone level. After collecting the report, we should inform immediately to the treating intensivist or the medical officer of our ICU. Ultrasound of abdomen should be there. Amylase and lipase should be monitored in the patient, those presenting the symptoms of decay. Here is the sign and symptoms of decay. As a nurse, we should have to identify the patient's symptoms. Now, either it is subjective or it is objective. We should monitor the symptoms. So we should more focus on the patient verbal symptoms, and also we need to monitor the symptoms on our senses. The first one is the feeling tired and sleepy. If patient is explaining us, I am feeling tired or I am sleepy, then we should watch about it. Confusion, passing out, patient is confused, he or she is having stomach pain, feeling sick, needing to urinate more, or high ketones, the blood vision, the thirstiness, and the sweet smelling breath. We should identify the sweet period of sweet smell in the patient. We observed while we are attending the patient in our shift, so we We are generally identify the head-to-toe examination of the patient while we are taking over of the patient. As a nurse, we should identify the symptoms of the patient, the high blood sugar levels. The treatment, as Sir said, IV fluids, we should give patient according to doctor's prescription. We should give a volume expansion therapy to the patients. As a nurse, our role is to identify the IV sites properly working or not. We should monitor, is there any leakage while we are providing IV fluids to the patient. Patient is getting proper IV fluid or not. We are giving volume expansor to the patient. Is he or she, after giving the fluid therapy, he or she is showing some sign and symptoms, or there is any adverse drug reaction should be there. So we need to monitor all these things. IV insulin should administered as per order. So for IV insulin, we, as a nursing point of view, we should know about insulin preparation. If we are giving insulin as per doctor's order, but we should check the clumpness of the insulin. While we are preparing the insulin, we should identify the proper dose and the route, the site we are administering the insulin. It should be monitored by a nurse while we are administering the insulin. Then antibiotics, how to give proper dose of antibiotics. It is under the nursing observation. The electrolyte replacement therapy, as per prescription, we should monitor the electrolyte replacement therapy. While we are sending the sample, we should monitor from which side we are giving the therapy to the patient. So we should avoid that left, if we are administering the electrolytes from the left side. So we should avoid the sampling from the left side because there is chances of alter lab status. So this should not be there. If we are giving proper nutrition to the patient, so as a nurse, we should monitor the patient is taking proper nutrition or not, patient is refusing for the meal. So it should be not there. We should advise the patient regarding proper nutrition therapy. And as doctors advise, we should give nutrition to the patient. If patient is not taking proper nutrition, we should counsel the patient and also counsel the family to encourage patient to get good amount of nutrition. Then this is the diabetic ketoacidosis prevention. Here we should encourage patient to do more exercise while we are discharging the patient. Then we should advise to the patient for a healthy nutrition, that they should take proper meal while we are discharging the patient. Then don't use clump insulin while we are shifting patient to the ward or to discharging patient at home. So we should advise the patient that don't use insulin if there is a clumpness is there or the color of insulin is changed. So we should, as a nurse, we should give proper advice to the patient how to take insulin, what method should be used, and what is the site to proper insulin administration. So patient and as well as relative should know about the insulin taking sites and dose of the insulin. We should give guidance to the relatives and to the patients. Then regular doses and follow-up advices should be given by nurse, that this should be done at home, and you have to take proper doctor's visit if there is a sign and symptoms showing in the patient. So family should immediately consult to the consulting doctors. So we need to give proper prevention suggestion to the patient. Then these are the alarm signs. The picture showing the cerebral edema, then fluid overload, hypoglycemia, and the sudden deterioration in sensation. If patient is complaining for blocking nostrils, and we need to observe the rhinocerebral mucormycosis, patient fluid overload. We are giving, as I mentioned, that IV fluids to the patient. So staff should know about the edema and fluid overload. Is there any fluid overload is there in the patient or not? So while we are attending the patient, so we need to check patient skin integrity for pitting edema. If there is a fluid overload, that there is a pictures like edema. So we, as a staff, we should attend the patient and we should monitor the signs and symptoms. These are the alarm signs in the diabetic ketoacidosis. Patient sometimes deteriorate in sensation. Maybe he or she is not able to sense properly. So they we should observe, and they also tell us about their sensation. So we need to immediately inform to the medical officer or a treating consultant if we find that alarm signs in the patient. The nursing aspects, if we are treating the patients with diabetic ketoacidosis, if patient is in comatose, so we should give bedside mobilization to the patient. We need to monitor for aspiration. If patient is having severe vomiting and patient is complaining for vomiting or nausea, we should monitor for aspiration. There is chances of getting aspiration pneumonia, so we should monitor the aspiration if patient is having vomiting. Then watch for ulcer, because we know in diabetes they are generally not healing properly, and it is not in the speedy recovery phase while patient is getting ulcers. So we should monitor deeply about ulcers. For this nursing aspects, we should do proper head-to-head examination if patient is admitting with this kind of ulcers. If patient is unresponsiveness found in the patient, so we should immediately inform to the doctor, and we should monitor the signs and the symptoms in the patient while patient is in comatose. So we need to monitor the patient, the ulceration and the aspiration. If patient is on ventilator, so we need to monitor the airway, and we should properly secure the airway. Also, we need to monitor the breathing and the circulation part. So we need to identify the cyanosis, and if there is any cyanosis or any unresponsiveness in the patient, so we need to immediately inform to the patient. The nursing management part, the first one is nursing monitoring. What we should monitor in the patient. So firstly, we need to monitor the vitals, the blood pressure, heart rate of the patient. If patient is having tachycardia, tachypnea, so we need to inform the doctor. Check blood sugar. If patient is taking IV insulin, so we need to monitor patient blood glucose hourly. Administer IV fluids as recommended. Assess mental status of the patient. Generally, we found the patients in ICU, they don't having a proper rapport with their family. If they are feeling alone, or in their sickness, they have sometimes altered mental status. So we need to give proper counseling to the patient. Look for signs of infection. We can identify in their daily blood reports. Also, while we are monitoring the patient vitals, that if there is rise in the temperature, so it is also the sign of infection. So we need to monitor this in our nursing monitoring. Properly, vitals monitor should be there. Pulse oximeter should be there in wards for DKA patients. Continuously sugar monitor of the patient, and as per doctor's prescription and the recommendation of the treating consultant, we should administer the IV fluids to the patient. Here is some measures what nurses should take. If patients are on insulin pump, then look closely for insulin leaks. If we are administering insulin from the insulin pump, so we need to check tube connection and air bubbles in the patient, because ultimately leading to the pulmonary embolism or any severe complication if we lack in this small things. Talk to your doctor. If patient blood sugar levels are often out of your target range, if doctor said proper scale for DKA patients, so we need to administer insulin according to that, and we should check properly hourly insulin, and we should record it properly. We have to document in our nursing sheets regarding patient's sugar levels, and if it is lower than the range or more higher than the range, then immediately inform to the doctor. Manage insulin dose with the help of your doctor. Make adjustment based on patient blood sugar levels, what patient eat, activity levels, or during any illness. So we need to manage the insulin dose properly with help of our doctor. These are the quality parameters for nursing. If we are attending the patient with diabetic ketoacidosis, what should be the documentation of the nursing? So they need to monitor the ketone level of the patient, the potassium level, and the electrolytes, all electrolytes level of the patient should be monitored regularly. And ultimately, the first and the last documentation regarding the sugar level, it should be there in the nursing sheets. The information regarding the patient condition should be appropriate and it should be updated time to time to the relative as well as to the physician. If there is any changes in the patient behavior, if there is a changes in the patient's body fluids, in the urine, the smell in the mouth, we identify any symptoms in the patient. So we should give proper information to the doctor, and up to date information we should have about our patient. The observation is the third quality parameter. The nurse should have a proper right observation from head to toe about the patient, because from a head it starts showing symptoms up to the feet, because we need to monitor edema in the patient. We should monitor the dehydration symptoms. As I mentioned, we should monitor the cyanosis. We should monitor all the vital parameters of the patient. So proper observation techniques of nurses should be there, so they can easily convey their message to the treating consultant or the medical officer of their area. These all are the quality parameters. Appropriate documentation, information, and observation of nurses should be there. The nursing care plans for diabetic ketoacidosis. As per NANDA, North American Nursing Diagnosis Association, I have taken a few nursing care plans for diabetic ketoacidosis. First is ineffective breathing pattern. It should be there in the patient because of deep, fast respiration, and it can lead to compensation of metabolic acidosis. It is showing symptoms in the diabetic patient. So we need to assess this kind of breathing pattern of patient. For that, we should properly give a position to the patient. We should monitor the patient. For this nursing diagnosis, what nurses should monitor, the proper subjective data should be there, and the patient is having tachypnea, the patient is showing any breathlessness. So patient also informed us that that is the subjective data of patient, and the nurses are monitoring the rate and the rhythm in the monitor which is attached in ICU for each and every patient. The second one is imbalanced nutrition, which is less than body requirement, and that is related to inability of tissue cells to use glucose, and the patient is complaining for nausea and vomiting. So it should be there in the patient. Patient is not taking proper nutrition according to their body requirements. So imbalanced nutrition status should be there. The third one is dehydration, that is related to increased urination and vomiting. Again, the vomiting is the cause for dehydration and imbalanced nutrition status. If nurses are observed patient is having nausea or vomiting, they should immediately inform to the doctor, because it can lead to severe complication. The fourth one is deficient knowledge related to new onset of diabetes mellitus. Some patients are there, those having recently diagnosed with diabetes type 2, diabetes mellitus type 2 and type 1. So generally they are not having proper knowledge regarding diabetes. So they are confused and they are not properly informed. So they should, we should give proper guidance to the patient as well as to the relatives regarding the disease condition and the symptoms and the treatment part. Here is the nursing intervention, what nurses should do while we are giving care to the patient. So nursing, firstly, we need to perform a rapid assessment with airway, breathing and circulation framework and assess the level of consciousness. This is the initial part of nursing intervention, that we should give proper airway, breathing and circulation to the patient. We need to monitor the conscious. If patient is in ICU and in comatose condition, so we need to monitor their airway and we need to secure the airway of the patient. By frequently suctioning, the breathing should be proper while we are giving semi-Fowler's position to the patient. Then initiate a continuous IV insulin infusion as per order to lower serum glucose level. So while we are treating the patients with diabetic ketoacidosis, as per doctor's order, we should start IV insulin to the patient. So proper secure IV line should be there. Or if patient is on CVP line, so we should monitor CVP line leakage while we are starting infusions with insulin. So it should be going or not. We should monitor frequently for leaks and all these things. So it is nursing care, nursing part of care. So monitor potassium level frequently during treatment and replace as order. Because there is hypokalemia or hyperkalemia seen in diabetic ketoacidosis patient. While we are replacing the potassium fluid to the patient, we are giving potassium chloride. So we need to monitor the site of IV. If patient is complaining for burning sensation, then we need to inform doctor. Assess the patient's fluid status. As I mentioned, the edema part we should assess, and we should give proper position to the patient to. For a comfortable position, we should give to the patient. Then we should identify a proper history. So we need to identify proper medical history, surgical history of the patient. If patient is female, then we need to identify gynec history of that. Then give health education to the patient. In that, we need to give proper education regarding diabetes self-management education and diabetes self-management supportive treatment. As a nurse, we should have proper guidelines regarding diabetes self-education and diabetes self-management support. So we need to give proper identify to the proper health education regarding diabetic care to the patient. What should be taken care while patient is discharging from a ward or ICU. So we are giving proper health education regarding diabetes. What should be the care of the patient in home? So we are treating patient with diabetic ketoacidosis, and we are giving proper health education to relatives. So here we are giving the list of their insulin doses and how they can take it at home. And here is the worsening sign and symptoms of the patient. If patient is complaining more about patient is more in confusion, or patient is talking about discomfort, and suddenly patient is unresponsive in hospital, so what are the initial steps they should take care? So we need to give health education to the patient, give adequate nutrition to the patient while patient is in hospital area. So we need to give nutrition as per dietitian orders, and as doctors said us, that low potassium or high potassium diet to the patient, normal diet, or if patient is on rice to feeding, so we need to give proper NG feeding to the patient that set by doctors. So we should monitor adequate nutritional status of the patient. The nursing evaluation should be there. After giving proper nursing management and nursing care to the patient, we should identify the resolution of acidosis, is there or not, is there any symptoms of acidosis. So in ABG they are showing metabolic or metabolic acidosis, so we need to identify there is a resolution of acidosis is there or not. Then if patient is hemodynamically stable, then we can shift to the ward, or we can give discharge to the patient as per doctor's order. If patient is eating orally, so we need to inform physician for to stop fluid therapy after discharging or after shifting to the ward. If patient is taking proper nutrition, so we need to give adequate guidance to the relatives that what are the insulin subcutaneous their time and the dose of insulin. We should instruct the relatives, then inject subcutaneous insulin 1 hour before stopping IV insulin. So we can identify the glucose level in their ICU or in the hospital side, and then we can give proper guidance regarding subcutaneous insulin, how to administer this, and what should be the technique should follow at home or in the ward side. Here is some complications of diabetic ketoacidosis. Hypoglycemia is there, hypokalemia. So we need to give replacement therapy to the patient. For hypoglycemia, we should administer proper dextrose to the patient as per doctor's order. The loss of consciousness, it is the major complication of diabetic ketoacidosis patient. And sometimes diabetic ketoacidosis leads to death also. So here is list of complications that happens in the patients with diabetic ketoacidosis. The reference I have taken from National Diabetes Fact Sheets and NJCYC and National Guidelines. Also, I took reference for nursing diagnosis from Nanda. Thank you, everyone. Thank you, sir. So hope you all understand regarding nursing part of diabetic ketoacidosis.
Yeah, Thank you, Mickey. I think very well explained. And now it's time to have discuss some questions and the chat box. So I think one question was left to Dr. Deepak. So regarding the saline resuscitations in diabetic ketoacidosis. So Dr. Deepak, if you're there, so just there is a question like normal anion gap metabolic acidosis in case of diabetic ketoacidosis when the patient is being resuscitated with normal saline.
Yes, sir. Yes. I think as we already discussed, like fluid actually is quintessential in the early part, normal saline especially. But as you hydrate more and more, like there's a part where there will be a overlap between hyperchloremic acidosis or normal anion gap acidosis and high anion gap acidosis secondary to DKA. So you need to. The question was what, sir?
Yeah, the question is how reliable is anion gap closure reliable to diagnose is resolving decay?
Anion gap is pretty useful actually, and it is actually one of the tools to monitor and to assess the severity as well. As the anion gap closes, that indicates that the DKA component is coming down. But at the same time, there's a part where you aggressively hydrate with normal saline, the acidosis persists, but the anion gap is actually closed. There you need to evaluate if they overhydrated with a chloride containing solution. The part is where you need to cut down the chloride, and most of the times it comes back. But the specific antidote, if there's a significant hyperchloremic acidosis, bicarbonate.
Okay, I think thank you. And I don't find any further questions in the chat box. So I think we'll close down the meeting. Just my one question to Mickey. So can you just explain how do you monitor the this ketosis on the bedside? Like how do you measure the ketones? Do you routinely monitor the urine ketones, or agent from the nursing prospect, do you do the serum ketones for every patient?
Sir, we generally go through serum ketones. We not mention any ketones at bedside.
Okay. Okay. Thank you. Okay. So thank you all of you, and thanks for the this today's wonderful webinar and well presented by both the speaker. And I would like my sincere thanks again to the Apollo, the Critical Care Academy, who is promoting the knowledge and sharing the knowledge among all the staff and the intensivists. So we'd like to have such more and more webinar further to enhance the spread of the knowledge. And thank you for the organizer, the Apollo Hospital, the team, and to all the presenters and to all the delegates from my side. Thank you.
Thank you, sir.
Thank you, sir.
everyone.
Thank you.